Soomaaliyeed mudanayaal iyo marwooyin marti sharafta dhakhaatiirta ka soo qayb gashay xafladan sanad guurada saddexaad ee loogu dabaaldegayo aasaaskii ururka Dhalmadoonka Soomaaliyeed Suroon waxaan idinkaga mahadcelinayaa waqtigiina qaaliga ah sida aad noogu soo hurteen oo aad noogu timaadeen waxaan kaleeto u mahadcelinayaa idil ahaan bahda saxaafadda oo ka soo qayb gashay xafladan waxaan jeclahay inaanu ku furanno haddii Allaha awoodda leh uu ogolaado ayadaha Quraanka Kariimka ah waxaana inoo akhrinaya sheekha da'da yar fadiilatu sheekh Ibrahim Ali
إن الذين قالوا ربنا الله ثم استقاموا تتنزل عليهم الملائكة ألا تخافوا ولا تحزنوا وأبشروا بالجنة التي كنتم توعدون نحن أولياؤكم في الحياة الدنيا وفي الآخرة ولكم فيها ما تشتهيه أنفسكم ولكم فيها ما تدعون نزلا من غفور رحيم ومن أحسن قولا ممن دعا إلى الله وعمل صالحا وقال إنني من المسلمين صدق الله العظيم
صدق الله العظيم وبلغ رسوله النبي الكريم إلهي hanagu anfaco aayadahaasi Quraanka Kariimka ah kuwa u dhagan uglaadana haynaga yeelo barnaamijkii ayaanu markan guda galeynaa waxaan jeclahay in aan codbaahiyaha ku soo dhaweeyo madaxa ururka Dhalmadoonka Soomaaliyeed ee Suroon Marwo Sharaf Fartuun Wali ku soo dhawow Fartuun
ilaaba maxalle waxaan kaga mahadcelinayaa imaanshaha imaateen maanta walidada imaanaya laakiin waxaan rabaa inaan idin mahadceliyo si aad iyo aad imaanshaha iyo saacidaad aan soo saacideen adduunka saacidaada lacag kaliya ma ahan imaanshaha imaanaysaan oo aad neelb garanaysaan oo maalintii loo dabaaldegayo dadka walaalaha ah ama ilmaha la'aanta ku dhacaysa ama raadinayaan inay ilaahay wax siiyo marka maanta waxaa noo jooga dhakhaatiir ka imaatay University of Minnesota specialist waa dadka inay ama ilmaha ku beeraan ama ay saacidaan dadka rabaa inay wax helaan waxaan ku hadlayaa Ingiriis aan iyagu u soo dhaweeyo waxay ku hadlayaan waa Ingiriis sababtoo ah Soomaali ma yaqaanaan barnaamijku wuxuu noogu soconayaa waxaa noogu bilaabay Dr. Damario and then gabadha Rosie ku xigaysa and then gabadha kale ugu dambeynayso marka wax walba markay dhamaadaan insha Allah Soomaalihana loo turjumayaa without further ado please welcome and Dr. Damario.
Thank you very much. I appreciate the invitation to speak with you tonight. And this week is National Infertility Awareness Week. So, received a child. There is some information about how long it takes to have a child. And so this research is done in the 1950s and really hasn't changed much since then. So when couples are trying to have a child, when they're actively trying to conceive, about half of them conceive within the first 3 months, about 70% within the first 6 months, and about 85% conceive a child after a year. Next slide, please. So we have to determine when is appropriate time that couples should seek assistance. And we have a professional society, it's termed American Society of Reproductive Medicine. So they set forth some definitions. So we do use these because we use these definitions to counsel patients about when they should seek care. And so the definition for infertility, according to our society, is a disease that's defined by the failure to achieve a successful pregnancy after 12 months of trying. having intercourse between the man and the woman. 12 months or 1 year. This definition, however, is modified because we think earlier evaluation is warranted if the woman is older. So for instance, if the woman is over the age of 35 years, then we think it's worth consulting a specialist after 6 months of trying. What is the incidence of infertility? In other words, in the population, and as Fartun was mentioning, it's blind to ethnicity. So in Caucasian and in African descent patients, the incidence is about the same. So about 10 to 15% of couples are affected by infertility. This means approximately 1 out of 8 couples experiences some problems. Okay, this slide, it's hard to probably read it from your chairs, but it's breaking down the causes of infertility. In other words, when is it attributable to the woman? When is it attributable to the man? When is it attributable to both? Or in what percentage of the time do we not really know? Is it attributable to the man or the woman? And what I'd have to say is that these colors on the bottom are reflecting problems that are related to the man. And sometimes I think that isn't as appreciated because, of course, the woman has the baby and carries the baby, but a lot of times the fertility problem can derive from the man to begin with. In other words, the man may not have adequate amount of sperm, adequate number of sperm. The sperm and egg have to come together to produce a baby and a child. And I'll just point that out to begin with. We usually know the cause of infertility in about 85% of the couples. So about 15% of the time we don't know. And when, like I said, when we do know, it's pretty close to almost half that are related to the man or the woman, and sometimes a problem with each. So anyway, as couples are seeking care through us or some other provider or physician, how do we counsel patients when they're preparing for pregnancy? Because when we see couples who don't have a child, they will be preparing themselves for pregnancy. So we have some general advice. I'll start with some advice for the women planning pregnancy. It's ideal if a woman is trying to achieve a normal weight. So if a woman is underweight, if she tried to gain weight, that would be advisable. If a woman is overweight, sometimes it's good to try to lose some weight. Smoking cigarettes, we would usually advise that women try to reduce or stop. Avoid other types of illicit drugs. Alcohol can be a problem as well if it's high. And we also advise women to take a vitamin supplement. And this should include what's called folic acid, and that limits certain types of birth defects, so we advise that. Sometimes that's termed a prenatal vitamin. We advise women to try to keep track of their menstrual cycles. In other words, when did one start? When did the next one start? When they are able to tell us that, we can determine if it sounds like a woman has normal cycles. There's also ways that women can do temperatures to determine if their cycles are normal. We can advise patients how to do that. There's also kits that you could pick up in a pharmacy that a woman could use to check her urine to determine if it's at the time that she's fertile or the time that she's ovulating or releasing an egg. Sometimes we advise that. How about men? For men, we also talk about trying to reduce smoking or stop smoking, avoid other recreation drugs, moderate alcohol as well. So a lot of these are just general health tips. We think it might be good for men to take a multivitamin too. because that could help their fertility potential in some cases. For men, we just advise to try to avoid hot baths, saunas, whirlpools, or high temperatures in the bath, as well as tight-fitting clothing. Next slide. Okay, so if a couple comes to see us, what happens? So what happens during an infertility evaluation? Back, please. I'll just point out that there'll be a medical team, so it'll be a doctor, and a doctor has a bunch of people helping them. We have nurses, we have office staff, we have scheduling staff, laboratory staff. So a doctor needs a whole team, a medical team, to see patients. And then for an infertility evaluation, as the picture depicts, we like to see the man and the woman. Who performs infertility evaluations? Well, a gynecologist can. And a gynecologist is a specialist, a doctor that specializes in a woman's reproductive system. There's a type of specialist that's called a reproductive endocrinologist. So I am a reproductive endocrinologist. A specialist like this specializes specifically in the identification and treatment of infertility. A urologist is also a doctor that specializes in a man's reproductive system. So sometimes it's inappropriate for a man to see a urologist for a fertility problem. Okay, so what happens when patients come to the office, and what do? We obtain a history, a medical history from both the male and the female, because we want information about both. We likely recommend testing, because there's different kinds of tests to be performed to determine what the cause of infertility is. So we do recommend testing for both the woman and the man. Some common tests, and I'll get into this a little more as the slides proceed, but some common tests are some hormone tests, blood tests of the woman, what's called a hysterosalpingogram, or an HSG, which is an X-ray of the fallopian tubes for the woman. A pelvic ultrasound or a vaginal ultrasound is another test to evaluate the woman. And there's a test to evaluate the man that's called the semen analysis. And this is looking at the man's emission, or the man's semen, to count the number of sperm and the appearance of the sperm in the semen. In certain circumstances, we do additional testing. And in certain circumstances, there are surgical procedures that are sometimes necessary for the woman, including procedures that are termed laparoscopy and hysteroscopy, which can check a woman's reproductive system. When women have some hormone tests, some of the tests that we do is trying to determine if a woman is having problems related to her age, because as a woman gets older, her fertility can decline. So some hormone tests are called ovarian reserve tests, and these are done to try to determine that. Normal results with these types of tests imply a normal number of eggs and good fertility. Abnormal results imply lower number of eggs and lower fertility. So we try to assess that. The specific hormones are called follicle-stimulating hormone, anti-Müllerian hormone. As a woman gets older, what happens? Well, unfortunately, fertility does decline, but that varies amongst women. So some women who are older, and many of you have probably heard of older women having children, but it does become more difficult. There's an increased risk of having infertility. There's also an increased risk of a pregnancy loss, or what's termed a miscarriage. So as a woman gets older, the risk of miscarriage increases. Also, there's an increased risk of having a baby with a genetic problem. If you are aware of Down syndrome, which is one type of genetic problem, that's an example. And the risk for that is increased as women are older. Also, some of our fertility treatments aren't as successful for women who are older than they are for women who are in the younger age range. So we have to evaluate several things. I'll just go through some of these things. We'll start with some of the tests for women. So we have to determine, is a woman ovulating? Ovulating means release the egg. And a woman releases an egg every month in her cycle when she's fertile. So we try to determine that. One way we do that is try to determine her menstrual cycles. I mentioned before that it's helpful to sometimes track them. So we get from the woman how often her menstrual cycles are, and we try to determine if the temperature charting, which I referred to, sometimes we have women chart their temperatures every day, and we try to see if there's a change in the temperatures that suggests that the woman is ovulating. There's also the urine ovulation test that I mentioned before. So at the middle part of a woman's cycle, she could do this testing to try to determine she's ovulating. And this is an example of what could happen on a temperature chart where a woman is recording her temperature. In the early part of the cycle, the temperatures are a little bit lower. But if she did ovulate, then in the second part of the cycle, we can see the temperatures go up. So a temperature chart with a rise in temperature can sometimes be seen. So if a woman isn't ovulating, what could be the reason for that? There are conditions. I'll just mention a couple, and I won't focus on this too much. But there's a condition called polycystic ovarian syndrome, and this is relatively common. About 2 to 4% of women have it. They ovulate some months, but not others, typically. And they could have a harder time getting pregnant. Sometimes they also have problems with acne or excess hair growth on the face or the body as well. Some women have what's called amenorrhea, which they don't have any menstrual cycles. Some women have that because they're underweight. Some women have that when they really exercise a great deal. And that's another reason why women may not ovulate. The third condition is called premature ovarian failure, or what's called premature menopause. This is when a woman goes through what's termed a change of life, where her menstrual cycles aren't coming anymore. And unfortunately, if that has happened, we really don't have any real good fertility treatments for women who have experienced that. Sometimes women could consider what's called donor egg, which is receiving eggs from other women. But I know a lot of couples, and perhaps a lot of couples in the audience, may not be comfortable with that kind of means of trying to have a child. We have treatments for ovulation. So if a woman isn't ovulating, there are medications that can be taken. 2 medications are called Clomid and Letrozole, and these are medicines that they take by mouth, so they're pills that are taken. There's also what's called gonadotropin, so sometimes women take fertility medicines that are given in injection form to help them ovulate. So we have to look at other things. What other kinds of problems can happen with the woman? Well, you know, after the woman releases an egg, that the egg has to fertilize and come through the fallopian tubes. Through the fallopian tubes, the fertilized egg then implants inside the uterus or the womb. So if a woman has a blockage of the fallopian tubes, that's another type of problem. So we do have to check for that. I mentioned earlier there's an X-ray called a hysterosalpingogram where a dye test can check if the fallopian tubes are open. And there's also a surgical procedure called laparoscopy that sometimes we do in order to check the fallopian tubes. This just shows a diagram of if a woman had one of these X-rays. The dye is injected into the uterus and we could see it flowing through the fallopian tubes. Just a diagram of that. And this is just a diagram of the laparoscopy procedure, which is done in surgery, where a woman goes to sleep, is done in a same-day surgery through small incisions, where camera is inserted through the abdomen, and we look inside at the fallopian tubes. Reasons why a woman could have problems with the fallopian tubes is she could have chronic infection, and that has caused damage. She could have a prior tubal pregnancy or an ectopic pregnancy in the fallopian tube, and that could cause damage. Adhesions or scar tissue can cause damage, and a condition called endometriosis can also cause effects on the fallopian tubes. A lot of problems with the fallopian tubes can require surgery, but sometimes if there's a lot of damage to the fallopian tube, sometimes surgery is not as successful. So sometimes patients consider the treatment that's called in vitro fertilization, or IVF. And Rosie's going to be talking about IVF a little bit later. When we have to evaluate the uterus, what techniques do we have for that? We have the ultrasound procedure, where an ultrasound is used to look over the uterus. Sometimes we do a special type of ultrasound, which is called sonohysterography, where we could put something in the uterus to fill it with a salt solution, so we could get a better look of the very inside of the uterus. And there's also a surgical procedure called hysteroscopy, where we can insert a camera inside the uterus as well. This is a picture of the sonohysterography, which is the ultrasound where some saline solution is in. And there's a little growth inside the uterus that we could see there. And this is just a schematic of the hysteroscopy procedure, where a camera is inserted into the uterus. What kind of problems are there with a woman's uterus? There could be growths. Polyps are just growths that occur on the inside of the uterus. Scar tissue. There could be septations, or little walls on the inside of the uterus that have formed. Or uterine fibroids. This is a very common condition. These are tumors that come from the wall of the uterus, and they can grow and start to cause problems. When we have to treat a uterine problem, it usually also requires some form of surgery to correct that. Okay, so we'll shift over to men, and how do we check men, and what happens there. We do a procedure called semen analysis, so we ask men to produce their sperm. We know that sometimes men are uncomfortable with that, so we try to find ways to help with that. Men sometimes could collect at home if they don't live too far and bring the sample to us, or sometimes they could try to collect this type of sample in our office in the clinic. Once we have the sample to look at, they're looking at the number of sperm. They're looking at motility, which is the percentage of the sperm that are moving. They're looking at morphology, which is the determination of the shapes of the sperm. And there's the criteria for each of these to determine if it's normal. And for men, there's a lot of things that could be affecting them that is impacting their fertility. And this is just a list. And I won't go through every aspect of every one of these conditions, but just to know that there's a lot of problems that men can have that can impact their fertility. They can have injuries, they could have surgeries that affect them, they could have exposure to different medicines or radiation, toxins, etc. Men can have problems with what's called the ejaculation. That means emission of the sperm. That could not work, or it could actually go in the wrong direction, called retrograde. Sometimes men, in their reproductive tract, there's blockages. So men could have blockages where the sperm can't travel through. There's also hormone problems men can have. And there's a condition called varicocele, which is a dilated vein that happens in the scrotum that can affect men's fertility. So I just mentioned that there's a whole host of things that men can experience as well. When men are treated, sometimes if we know, what the specific problem is, we'll make a recommendation. And if a man is treated and there's a specific problem that has to be corrected, sometimes we do use a urologist. So I mentioned earlier that a urologist who's a male fertility specialist might help us. They can do different surgeries when it's needed. They could do different medical treatments when it's needed. And they could assist a lot of men. Sometimes there's just general treatments that are trying to help male infertility, where we could take the man's sperm and do what's called artificial insemination. This is where we inject the sperm into the uterus and try to help conceive a pregnancy. Then there's the second technique which we're going to talk about called in vitro fertilization, or IVF. And this is an important treatment because this is one of our most successful treatments. But I'm gonna let Rosie kind of describe that a little bit more for you. Insemination using donor sperm, this is sometimes considered, but like I mentioned earlier, a lot of couples may not prefer the use of sperm from another man for their treatment. But there are sperm banks that do provide sperm for women if they wish to consider that type of treatment. This is just a diagram of how artificial insemination works, where a sperm sample, when it's prepared and processed and ready, is placed inside a woman's womb. So in general, what can we say about infertility treatment? We can tell you that it's not a guarantee. So if a couple sees us, we try everything we can to determine the costs. We try what we can to recommend appropriate treatment for the cause that we've identified. But it's not a guarantee that it will result in a child. However, there are many successful couples. So many couples do succeed with this. It requires the active participation of both the man and the woman. Many couples require multiple treatments, so sometimes they have a treatment. If it doesn't succeed, we might have to repeat the treatment, and sometimes we have to repeat treatment several times. And it also requires a significant amount of time to undergo the medical assessment, the evaluation, as well as all the components of the treatment. If you have infertility, what are some things to think about? And what are some questions to ask your doctor or your medical provider? One thing to ask is, what is the reason or reasons that I cannot conceive? Think about that. What is the prognosis that the fertility treatment recommended will be successful? In other words, what is the estimated chances that that treatment will succeed? What are the costs of the fertility treatment? Sometimes we have to discuss costs with our patients. And does the insurance company, if you have insurance company, do they cover the costs of specific infertility treatments? Because sometimes they do, and sometimes they may not. So that's another important question. This slide, I know you can't read it, but I just wanted to show in our clinic a composition of all the people that help the doctors with patients with infertility. We have 2 doctors currently, but we have a 3rd doctor joining in August, a woman. There's also a nursing staff, laboratory staff, and a lot of people that we have to assist our couples. And our goal, and we wish this would happen, is that at the end, our patients have a happy baby. Thank you.
يعني markaa go'aan ku gaartid inaa ilmaha isku beertid dariiqadaha la maro xitaa anagoo af Soomaali ku hadlaynin iska dhaaf dadka Ingiriis ku hadlay ay xitaa dhibtaa marka si sahal ay u soo diyaariyeen insha Allah programku dhamaad waxaan isku daynaa videoga inaan translate gareyno so welcome.
Thank you. Wasn't that a great talk he gave? We learned lots, right? Okay, and hopefully I'm going to add a little bit more information to that. My name is Rosie. I am the IVF coordinator in our clinic. What that means is when a couple or a patient decides that they're going to do IVF, I'm there to kind of guide them through this process because it's a very complicated process. It has a number of steps to it. And I'm there as a resource to help them to kind of organize their appointments and then to actually schedule their procedure at the end of the journey. So with that, I'm going to go ahead and get started talking about IVF. Now, one of the things that I find is that this is confusing, and oftentimes patients get IVF and IUI mixed up. IVF is what I'm going to be talking about, which is probably our most complicated and technical treatment that we do. IUI is the intrauterine insemination that Dr. DeMario mentioned a little bit earlier. It's a little bit less involved and quite a bit less expensive. Now, oftentimes patients do other treatments prior to doing IVF. IVF, because of the cost and because of the fact that it's quite technical and time-consuming, is usually the last type of treatment that a couple does. Now, there are certain circumstances where it may be their only treatment, but in many times they have done other treatments prior to doing IVF. So we recognize that sometimes you have been at this a very long time by the time you get to this treatment. Now, some simple definitions. I tried to kind of make this pretty easy to understand because it is hard. So I want to assure you, if you're thinking about IVF, and you get to the end of this and you think, oh my goodness, this is really complicated. I don't think that we can do this. We will help you. We will take you through the process step by step. You'll get information along the way when you need to have it. So if you feel a little overwhelmed, that's really okay tonight. So in vitro fertilization basically is a process in which we stimulate the ovaries of a woman to make eggs. And we do that typically by using injectable medications that the woman will take and give to herself in her abdomen. And usually these injections are anywhere from about 10 days to even 3 weeks or so. After about 10 or 12 days of these stimulation medications, when the ovaries have made a number of eggs, and we monitor this with ultrasound, and it will involve a number of appointments at the clinic to kind of determine this, then she's given a shot, and it's actually one you will take yourself, ladies, that matures the eggs, and then we do a process called a retrieval, or transvaginal oocyte retrieval. We refer to it as something called TVOR. And in that procedure, while the woman is asleep, and it's done in our clinic, it's a fairly simple procedure done by either Dr. DeMario or one of the other physicians. They remove the eggs with a needle by going through the top of the vagina. Those eggs, along with the fluid that they're in, are then given to our embryologist in the laboratory, and they take those eggs and mix them with sperm to have fertilization occur. After fertilization occurs, they're kept in our laboratory in the incubators for a number of days, and either 3 or 5 days after that procedure, they will be transferred back into the uterus of the woman with a special catheter, and that's called an embryo transfer. And that's basically what the process is in very a quick, simple definition, but we're going to talk now about that in a little more detail. So Dr. DeMario, I think, has done a good job of giving you ideas of why infertility occurs and some of the different reasons. So I'm not going to really spend any time on this other than to point out this is not a complete list. It's a fairly inclusive list, but you'll notice the number one thing on the list is male factor. And I actually have to track the different reasons why we do IVF in our clinic, and actually male factor is the most common diagnosis that I see in our clinic. This is just some interesting facts about IVF. The first IVF baby was born in England in 1978. So it's really not all that long ago that we've been doing this process. Her name is Louise Brown. She's now, if I can do my math right, she's about 35. There were approximately 95,000 IVF cycles done in the United States in 2011. This is the year that we have the latest statistics on. And this would be referring to cycles where a woman used her own eggs. And in our clinic at Reproductive Medicine Center, we do approximately 350 IVF cycles a year. As Dr. DeMario mentioned before, it takes teamwork to do this. And in the course of an IVF journey, you will encounter all of these different groups of people at our clinic. I just want to point out a few. Down when you get to the embryologist is the person that's going to be dealing with the eggs, the sperm, and the embryos. They're a very, very important part of the IVF team. We have 2 embryologists at our clinic. They both have PhDs. They've been doing this a very long time, and they're actually very good at what they do. Right next to that is something called an andrologist, and that's actually an infertility specialist for the male. We mentioned the reproductive endocrinologist, of which Dr. DeMario fits into that category. And then I am the IVF coordinator, as I said earlier. Also want to point out at near the very top is our financial counselor. Our financial counselor plays a huge role in this because, unfortunately, it's not covered by a lot of insurances. So we need to kind of figure out from the beginning, is this something that's realistic for your family's budget? The timing of an IVF cycle is sometimes a little bit of a surprise to couples. It's not a fast process. From when a couple makes the decision to do IVF to when they actually have their retrieval or their procedure takes about 2 to 3 months. About half of that amount of time is taken getting through the pre-screening process. The labs that Dr. DeMario was talking about for the woman, labs for the man, semen analysis for the man. There's an education class that we require that you take that helps to kind of educate you about this process, and all of that takes time. And then we place the woman on birth control pills, and from when she goes on the pill to when she actually has her retrieval is going to be about another 6 or 8 weeks. We also do not do IVF 52 weeks of the year. We do it about 30 weeks of the year, so we will kind of look to see where you might fit best into the cycle, and that might also delay you by a few weeks or a month. As far as the pre-screening steps go, just wanted to briefly talk about this. In an IVF cycle, there are labs that Dr. DeMario has already talked about, looking at the woman's ovarian reserve. There's the semen analysis for the man. Very important that we have that information. The woman based on birth control pills, as I said. Now that seems really strange, doesn't it? We're talking about infertility and we're saying you need to go on birth control pills. I get lots of confused looks and comments about that, and I'll tell you why we do it. There's 2 main reasons. One is it puts the woman's ovary in a resting state so that when we stimulate it for her IVF cycle, we actually have a better response. And the second reason is that it allows me to control her cycle so that we can move things along a little bit quicker and make things fit into the cycles. After birth control pills, we've talked about, I mentioned the class. There's a class that I happen to teach. It's held in the evening in our clinic, and it really is a very informational class that I think most couples find really helps to make all of this make a lot more sense when they complete that class. And the final step is coming in, meeting with the physician. Dr. DeMario kind of talked a little bit earlier about the sonohystogram, putting some fluid in the uterus with a catheter and ultrasound and looking at the uterine cavity to make sure there's no abnormalities. That's done, and once that's completed, we have you sign your consents for the IVF procedure, and then the financial person meets to collect any monies that are due, and then I sit down with the couple at the end of that appointment, and we actually talk about what date is your retrieval going to happen. There's 3 things that I schedule at the end of that appointment. One is the tentative date of your retrieval, and we actually use about a week because we can't give you an exact date. It depends on how you respond to these meds. I will order your meds at the pharmacy of your choice, and I'll help you with that, and then I'll actually set up your first appointment and kind of give you the basic instructions. So let's talk a little bit about medications, because that's a very important part of an IVF cycle. And I'm going to kind of list typically what you might need. So initially it's birth control pills, and it's anywhere from 2 to 3 packs of birth control pills is kind of average. The next medication is something called leuprolide acetate. This is the most common one, and again, please don't feel like you have to remember any of these names tonight. You don't. But this is a medication that's an injection that the woman gives herself daily, and it will actually give us control of the cycle so that you don't ovulate before we're ready to do your retrieval. Very, very important medication. The next medication is the stimulation medications, and these are the ones that really are the most expensive. And this can be pretty surprising to many couples. These shots are usually given twice a day, morning and evening, in the abdomen by the woman herself. And we normally use 1 or 2 different medications, and these medications cost anywhere from about $2,000 to $6,000 for one treatment cycle. The next medication that we would be using is something called HCG, and this is what actually matures the egg right before you have your retrieval. It's given 36 hours before. Your doctor will determine what day that should be given, and again, it's a shot that the woman would give herself. So in an IVF cycle, almost all of the medications that you take are by injection, and there's a small needle that the woman can do herself quite easily. And we do have a video in our clinic on our website that you can watch that usually will help you feel like you can do this. And we also have classes at the clinic. So if you want a little bit more supervision and want us to talk you through that first shot, we're happy to do that and let you practice with the nurse on that. The very first one is starting with the financial counselor. We encourage you to either call or stop by the clinic. You can do either one. It's wonderful if you can come as a couple. Gail right now is one of our financial counselors, but we do have somebody there 5 days a week that can sit down with you and talk to you about what an IVF cycle will cost, look at what your coverage is, and unfortunately, as I said, most people do not have insurances that cover IVF. So it oftentimes involves a lot of money that you need to sort of figure out what works for your budget. And that's the first thing we want to do, because we want to make sure this is a realistic and a good choice for you before we even start down the road for IVF. If you decide that, yes, this is a good fit for you, this works well for your budget, it works well for your family, then your next step would be to make an appointment to see Dr. DeMario or one of his colleagues, and then they'll do your assessment for the start of the IVF cycle. Your next step would be to contact me, the IVF coordinator, and then I will start kind of organizing your appointments and your labs and the things that you need, answer your questions, and kind of get you started on that. Then once you've completed the pre-screening, which I talked about earlier, it would be that consent signing appointment with the physician and that procedure called the sonohystogram. Then your medications will start, and that takes about 3 weeks from when you start the medicine, the injectable medications, all the way to your retrieval. And then you would have your retrieval, as I mentioned. The retrieval is done. It's done in our clinic. When you, with anesthesia, ladies, you take a little, what I call a power nap for about a half an hour or so when the procedure's done. And then that day you go home and rest. Either 3 or 5 days later, you'll be back in the clinic for the embryo transfer. And that is a day, again, where you will need to go home and be on bed rest. And I always kind of tease women and say, get your pampering plan ready. Let your partner know that you don't have to do any work that day. Just the TV remote is all you have to work with. No dishes, no anything else, and you're going to get pampered that day. Now, how much does an IVF cycle cost total? We just always want to, again, kind of let patients know ahead of time so there's no big surprises or shocks, because it is a lot of money, and we very much recognize that. The initial exam and pre-screening is estimated to be around $3,000. Some of you may have insurance that will pay for some of this, just very individualized. The IVF cycle itself is approximately $12,000, and medications are about $3,000 to $5,000. So when you add that all up, one cycle of treatment is somewhere between $18,000 and $20,000. And then I don't know that you can really see these. I'm not sure that it's going to be helpful to go through the photos. Can anybody see those? I wanted to just take you through a quick serial of what happened. The first photo was, if you back up one, Gail. This is a picture of an ovary that's been stimulated, and those little black circles on there are what we call follicles. And that's like a little fluid-filled balloon that would have an egg inside. This is what the doctor is going to put a needle into and suction the fluid out, and hopefully an egg will come with that. And that just is a picture of one ovary with a number of follicles. The actual retrieval process is what this little schematic drawing is. And I know many of you can't see it, but it basically is a picture of a vaginal probe in the vagina with a needle on the end of it. We make one puncture or one incision through the top of the vagina on one side. The ovary actually sits very close to the top of that, and the doctor will then move the needle around and suction out the fluid, and hopefully the eggs will come out with that. It goes into a little test tube, and then that is given to the embryologist, who then starts working with the eggs in the lab. The next picture is the way IVF started, and it basically is taking sperm that have been processed, and gentlemen, you will give us a sperm sample the day of your partner's retrieval. That's when we need that sperm. It's processed in the lab, and then it is mixed in with the egg in a petri dish with special fluid, and then hopefully fertilization will occur. And this is what is called in vitro fertilization, and that's how it got its name. Now we have a fancier way to mix eggs and sperm together, and that's called ICSI, or intracytoplasmic sperm injection. How's that for a mouthful? And in this one, which is done actually quite frequently, probably about, I'm guessing, about 75% of our patients have at least some of their eggs ICSI'd. What happens is the sperm is actually injected into the egg, and you're going to see a video. It's actually a very short one here. I think that will maybe work. And if not, we'll just move on to the next slide. But that's an actual real egg there, getting ready to be ICSI'd. And it looks like it's going to not cooperate tonight. I guess your embryos would have their own little private compartment, and these are the incubator compartments. That happens to be one of our embryologists right there working with the eggs. We have specially trained people in our lab that work with the egg sperms and sperm and embryos. And they're incubated anywhere from 3 days to 5 days typically before they're transferred back into the uterus. And that's going to be what the last slide is here. It's very similar to an insemination. We just use a much more precise catheter that has your embryos in it, and they're inserted into the uterine cavity through the cervix by one of the physicians and the embryologists. They do it as a team. And then we hope that 12 to 14 days later, you get good news and you have a positive pregnancy test. So how do you get started? It starts with a simple phone call, and that is our clinic phone number. We're happy to talk to any of you. Thank you.
Thank you, Rosie. It's easy to follow. What I forgot to say is that we have Somali ethnic media. We have Somali TV, but also we have Somalia TV. So the Liban is responsible of his video is shown in Somalia. So your audiences are not only from Minnesota. Our organization's education piece is followed all over the world, wherever Somalis are. So now Mogadishu is in peace, so they'll be watching. So I just wanted you to know that what you're doing today is very important, not to only Americans who are here, but also abroad. Saa ogtihiinbo in ubadla'aanta waxyaaba badanaa keeno waxa ugu weyn oo dhakhaatiirtan ay ka hadleen oo insha Allah la turjumi doono ta ugu daran oo dadkeena Soomaalida ah ee haysta cudurrada galmada ka imaado. sababta tahay Soomaali markaan joogno waxna lagu dhigi jiray ma sameyn kartiin xaraha sameynin waxna asmin soo ma naqaan sida cudurrada galmada la isaga ilaaliyo sida darteed waxa keen cudurrada galmada cudur kamid oo kalmidial dhoo inay ku badan tahay dadka Soomaalida ayna sameyso inay caabuq badan iyo infection badan ay keento gabadha iyo wiilka labada, taasay ka ilaaliso ama ay ka horjoogto inay gabadha ama wiilka labadaba ay ama wiilka gabadha uur yeelanaan gabadha uur yeesho. Mary waxay nooga hadlaysaa cudurkan chlamydia la dhaho, sida la isaga qaado, in waxyaabaha sababta ay keento inay ilmo la'aanta keento. Marka waxaan idinla soo dhaweynayaa Mary. Mary, take over.
Thank you. Good evening. My name is Practitioner. I also teach in the University of Minnesota School of Nursing. I'm very happy to be here tonight. What I'm going to talk to you about is sexually transmitted infections. There are a large number of sexually transmitted infections, but we really think of two that most often cause infertility. So that's what I'm going to talk to you about tonight. If you would, the next slide, please. The two most common sexually transmitted infections are chlamydia and gonorrhea. Now, when you think about chlamydia and gonorrhea, I can't tell you how often I see this in the clinic. It is very, very common. There are two things that you want to know about these. In addition to being common, young people are at more risk to contract. It's important to know because a lot of times young women sort of think they're invulnerable, but unfortunately they are more at risk because of some changes in their cervical tissue, which I'll talk about in a moment. So that's important to understand. If you would, the next slide. There are 2.8 million cases of chlamydia a year in the United States and 718,000 cases of gonorrhea per year in the US. So these are both very prominent diseases. If left untreated, about 10 to 15% of women who develop chlamydia will develop pelvic inflammatory disease. And I'm going to talk with you about that and why that's significant. If you would, the next slide. Earlier, Dr. DeMario talked to you about the uterus and the fallopian tubes and the ovaries, and this is sort of a model of what's inside a female. And if you can see these little stalk-like appendages on both sides, these things that stick out at the top, this is your uterus in the middle, and these are your fallopian tubes. What happens when you develop pelvic inflammatory disease is the bacteria starts to scar the inside of these tubes, and as our two former speakers just told us, when those tubes get scarred, the fertilized egg can't get through to the uterus. And so that's what we really run into with chlamydia and gonorrhea, is these tubes get scarred. It can also damage the uterus itself and the ovaries, which are these little round things on the sides over here. So this is what we are worried about when we have chlamydia and gonorrhea. So pelvic inflammatory disease is an infection of the uterus, the fallopian tubes, or the other reproductive organs. And the bottom line with that is, because you have infection in here, you get scar tissue, and you can't become pregnant. The symptoms very often for pelvic inflammatory disease, it may start out somewhat mild. A woman might think that she just has a bad stomach ache, but over time it can rapidly become very serious. You might get severe abdominal pain, nausea, vomiting, chills, high fever. They're very uncomfortable very often when they come into the clinic. Now, unfortunately, we don't like to see it get that far, so I'm going to talk with you in a little bit about what we can do to try to screen for these illnesses and then also to treat them. If you would go forward. For pelvic inflammatory disease, about 750,000 women experience an episode of PID, or pelvic inflammatory disease, per year in the US. Of those women who have the infection, 10 to 15% will become infertile. You do the math there, that's about 75,000 to 112,500 women who will become infertile due to the infectious disease. Another large percentage may have an ectopic pregnancy, and our previous speakers also talked about that. When you have an ectopic pregnancy, normally that fertilized egg seeds itself in the uterus, in the lining, but sometimes the fertilized egg will implant itself in the fallopian tube, and as it starts to grow, the entire tube may burst. And again, that's very painful. I think my mic is going. But in any case, what we want to do is prevent that. So we really need to do the screening and the treatment for the infectious disease. We can move forward then. So as I mentioned, pelvic inflammatory disease, or PID, can cause damage to the fallopian tubes and tissues in or near the uterus and ovaries and lead to very serious consequences. The two we talked about most are infertility and ectopic pregnancy. You should know that if the woman does have an ectopic pregnancy and her tube bursts, then she has a less chance of conceiving again. Also, you can develop an abscess formation or chronic pelvic pain. These are the women, it's very difficult to diagnose. Women will often come in and they talk about this recurrent pelvic pain. They're very uncomfortable, but we can't find a good reason for it, and this can be sort of a lifelong complaint. It makes sexual intercourse very uncomfortable, and again, they're less likely to conceive. Now, this is a picture of what it looks like inside, so when I show this model, that's what's inside the female body. You can move forward. So when we talk about chlamydia and gonorrhea, the symptoms of chlamydia are abnormal vaginal discharge, painful urination. They'll often describe a burning on urination. And the symptoms occur a lot of times weeks after the intercourse occurred. So you can't always put the symptoms together with that sexual intercourse. But more importantly, chlamydia is often a silent illness. There are no symptoms whatsoever. So a woman does not know she has this. The symptoms of gonorrhea are similar. You can have painful or burning sensation on urination. More commonly, I have women coming in with increased vaginal discharge, or they report abnormal vaginal bleeding, where they will bleed mid-cycle or they'll bleed more heavily than usual. But again, women may have no symptoms with gonorrhea. So chlamydia and gonorrhea, it should be noted, can also infect other areas in the body, the rectum and the oral passages as well. Now, male symptoms are a little different. You will also find penile discharge, usually a yellow, greenish color, a little different than what you're experiencing normally. There may be some blood in the penis on discharge. More importantly, they often come in with burning on urination. Infection of the male genital tract can occur, so if you don't catch the acute symptoms, the infection can sort of penetrate other areas, and you may come in with swelling or pain in the scrotal sac, or you may have some pain up in the place where the sperm is developed in the first place. So you'll just have other symptoms with that, and that can be difficult to treat. Now, the thing to notice here is that men are much more likely to have symptoms than women. So they're more likely to come in for treatment, but then we really have to have men telling their partners as well that they've been infected and treated for this. Without that, the women may go on and have an infection and not know. So the Centers for Disease Control in the United States has some recommendations for screening. They will recommend annual screening for any woman under the age of 25 who is sexually active, and for older women who have risk factors such as a new sex partner or anyone who has multiple sexual partners. I know in most of the clinics where I work, when we have a young female who comes in with urinary symptoms, this is recommended that we do on those patients. In addition to screening for a urinary tract infection, we also screen for chlamydia and gonorrhea. So the treatment is pretty simple. It's antibiotic treatment. For chlamydia, you can actually do just a one-day course of azithromycin, which is a macrolide antibiotic, or you can do a 7 to 10-day course of doxycycline. So the treatment is relatively simple. Now, gonorrhea usually requires an intramuscular shot of a cephalosporin medicine, and then there are some other options along with that. They recommend that you take, again, the azithromycin and doxycycline, but you have to have the shot. The unfortunate part is we're seeing increasing resistance of gonorrhea to many of our antibiotics. So that's a very changing bacteria and becoming more difficult to treat. If a woman is pregnant and is found to have chlamydia or gonorrhea, it's really important to treat that infection before she gives birth. And the reason for that is the baby can pick up the infection as they come through the birth canal. And when they do that, it can cause eye infections, they can get it in their lungs, they can be very ill. So it's really important that we screen during pregnancy and that those women are treated. If a woman is found to be positive for gonorrhea, we automatically treat for chlamydia as well, because they tend to come together. The opposite is not true. If you have chlamydia, you won't necessarily be treated for gonorrhea, but you certainly will if you have gonorrhea. So, how do we prevent these illnesses? There are a number of ways. One, of course, is abstinence, not having sex until you're married and you have one partner, making sure that you're both monogamous, meaning that both the female and the male in the relationship have only one partner. The more partners you have, the more at risk you are of contracting a sexually transmitted infection. There used to be a good poster we had in our clinic that I thought was really helpful. It had a male and a female, and it said, when you go to bed with this person, you're also going to bed with all the partners they've had before. And you could just see how that would multiply, because then you go to bed with the partners that partner has had. So you really need to think about that. Abstinence, of course, is the primary prevention. Consistent condom use has been recommended. I just read an article this week that condoms may not be 100% effective for chlamydia or gonorrhea either. So that's another thing we have to think about and be careful. And then knowing your partner and knowing the risks for chlamydia and gonorrhea are important. We are really telling young women to ask their partners if they've had sexually transmitted infections or if they currently do. I have some partners who come in together and they require testing so they know who has what. It seems not quite as romantic, but it's a healthy way to do things and to live. So you might want to think about that. And then also regular screening. As I mentioned, when young women come in, and if they're sexually active, we really strongly recommend that they get chlamydia and gonorrhea testing. I also encourage young men, if they have any symptoms, to come in and be tested. And then after infection and treatment, we used to do a test of cure, meaning that we would see if the infection was gone. We don't always do this now. In some cases, I will, but your provider will recommend that. And I think that's probably it. So.
And I'm going to try and, take the most frequent one that have been asked. Dr. Kanit su'aalaha gabdhaha soo weydiiyeen iyo wiilashaan weydiinayaan dan hadhowtidiya turjubina. One of the things that I heard is that fear of IVF. So it's like if my husband comes and gives his sperm, I may get a sperm from a white person or African American or a Hispanic person. Can you talk about how when the husbands or the men give their sperm, how is that protected, and make sure that the right person gets the right sperm? Thank you.
Well, this is obviously something that has to be managed very, very carefully. It is true that in these instances where we are doing in vitro fertilization, the sperm is out of the body, the eggs are out of the body, so we definitely have to have the right sperm with the right eggs at all times. And so when a man is doing the sperm sample, for instance, if he brings it from home, we do very careful identification. So sometimes men forget that, but they need their driver's license or their form of ID. And we have to see for sure that is the man that is attesting to that sample. Everything is very carefully labeled. And so it's stored in very careful systems. Even when we are freezing sperm, if we are, that's in very certain designated containers that are also very carefully labeled. When a woman is doing her part and we are retrieving the eggs, we check her identification same way. We confirm with the embryologist who the patient is. We actually do that with the patient while the patient's still awake. And then the eggs are out of the body, and then that's very carefully labeled too. So all the dishes are in certain places of the incubator, and we are as careful as we can about that, all those procedures.
Lagu talaalo Soomaaliya marka waxaan ku yiri see u sameeysiin oo u hubisiin si qofka wixiis qof islaam wixiis aan gabar lagu beerin marka su'aashu ka jawaab waxaad waa ilaalinaa nambaradan ku dhijinaa qofka nimanka markay keenaan spermkooda shahaadadoodii in travel license-koodii waxooda inay keenaan si loo ilaaliyo laakiin wuxuu yiri waa ka taxadarnaa su'aasha kale oo raba inaa weydiiyo waxweeyaan gabdho badan oo Soomaaliya ah waxay ka cabtaan in ay hormoonkooda ziyaado yahay laakiin cabsiday ka qabaan inay uur yeeshaan dartood marka lagu yiraahdo hormoonkaaga wuu kacsan yahay oo islama sinna marka ugxamaaga caadi ma noqonayo still waxay isku dayaan inay qasab yani uurku yeesho because walaaci yahaayo su-aasha marka weydiinayo waxa waaye haddii hormoonku ziyaado yahay maxaa samaysiin oo aad caadi uga dhigtiin. The other question that I wanted to ask that I got I'm kind of a bias, so I'm asking all the questions from the sisters, is that a lot of the women that we help have like their hormonal is imbalanced. So some of them would say I didn't get period for 6 months, some would say 5 months, but they're still determined to get pregnant. And if you may tell them your hormone is not normal, you have to go through some sort of a period of waiting to balance your hormone. They're still determined not to go through this process. What kind of advice would you give those women who have their hormone is imbalanced but yet don't want to listen? Thank you.
Well, I think, there are examples of women having an imbalance and then having some menstrual cycles. So they may miss a couple cycles in a row and then they'll have a menstrual cycle. Well, they may ovulate, and they possibly could get pregnant even in the month that they ovulate. But the problem that they face is they ovulate or release an egg less frequently than other patients who ovulate each successive month. And so it's possible that sometimes patients with those kinds of problems can still achieve pregnancy, but they're facing more of a challenge. Basically, if a period of time goes by, if they are irregular and they haven't gotten pregnant, then we would encourage them to seek assistance because we can treat many ovulation problems. Then sometimes we also don't know if somebody has a irregular cycle, if there's other hormone imbalances too, because sometimes other health conditions could be occurring. And so sometimes it still is worth to have a checkup if the menstrual cycles are not regular.
The last question I want to ask you about the female side is a lot of like their tubes are clogged, whether through the circumcision, infection, through some sort of whatever happened, ectopic pregnancies, and they go through surgeries. And sometimes surgery does not guarantee that the fallopian tubes will be open. So what advice would you give a woman who has fallopian tubes that are blocked, and she's like maybe 30 or she's going to 35? What kind of advice would you give instead of trying to have surgery and take a chance of the fallopian tubes being opened? What kind of advice would you give so then they can do, what is the quickest way? Actually, that's the question that women ask. What is the quickest way to get pregnant?
Yes, and so one of the main aspects of this is that there's different degrees of damage that we could determine if the fallopian tubes are blocked. Two different ways that we appraise that is through the X-ray or the hysterosalpingogram, also the laparoscopy, which is the surgical procedure. Basically, if the fallopian tubes are blocked and we think that there still is some indications that behind the blockage is still a relatively healthy fallopian tube, then we believe that surgery would be more worthwhile because the results are better. And so sometimes we see this in terms of characteristics on the X-ray, that we could see a pattern that still looks fairly healthy, but it still is blocked. Also, when the fallopian tube is more damaged, it dilates. And the more it dilates, the worse chances we have with the surgery. So in the better cases, the surgery might be in order of about 60 to 70% chance for conception. But in the worst cases, it might have only about a 10 or 15% chance. So it's those patients who have a lower chance that maybe that's not the best thing to do, where surgery's chance to have a child is lower. Sometimes those patients consider the IVF treatment as an alternative.
The last question is for the mayor. Last year, 2012, when we started Restaurant, everyone thought we were only for women. We are a reproductive health women organization, but that doesn't mean we're not concerned about male reproductive health issues. So last year and this year, I've got men who are calling from Somalia, but also around this state that they have pluggage. I don't know what the terminology is. I think I forgot it, but they cannot ejaculate. So their sperm goes back to their kidney, and they're unable to conceive that way. What procedure do you do to get their sperm out and maybe inseminate, because inseminate the egg, or they maybe end up doing IVF? I just want to explain to Somali. Su-aashaan weydiiye waxay tahay wiilal badan oo Soomaaliya jiraan oo cudur kaga dhacay xaniyaha ama wax ku dhaceen oon ka imaanaynin miinada aysan ka imaanaynin marka uur gabadhi ma u yeeli karaan. Su-aashaan weydiiyaa waxay tahay maxay ka sameyn ninkaas Soomaalida ma camaliyu sameyn karaa si uu spermadiisa loo soo bixin karaa si uu gabadha uur ugu yeesho? Please answer. Thanks.
Yes, and so there are some problems with men, and we're discussing issues where a man the emission doesn't occur properly, so the sperm doesn't come out, and sometimes it can go backwards. It goes backwards into the bladder is where the sperm goes, and so in those instances we may have the man see a urologist, because sometimes a urologist can help. In some instances, there's medicines the man can take, and that sometimes that helps that. So sometimes a urologist will prescribe a medicine, and the emission, instead of going backwards, can be some medical treatments can sometimes help that. If medical treatments can't help that, then sometimes we're able to get the sperm. The way that works is a man will have emission, but it goes backwards into the bladder, and we could have them empty the bladder and actually collect the sperm. So that's called a retrograde, which means the sperm is going backwards, and we do collect urine and try to take the sperm out of it. In some instances, if we collect enough sperm, we can use artificial insemination, but a lot of those instances we may not collect a large number of sperm. So sometimes we have to use sperm in an IVF treatment or something like that. So those are some things.
Thank you so much. So now I'm going to ask Mary. Mary waxay ka hadashay cudurrada galmada ka imaado oo gabdhaha wiilasha dhalaanta u keeno. We know that chlamydia, like we talked about, having adhesions. We hear adhesions or scars. When women trying to get pregnant and she sees, say, Dr. DeMario, and she says she wants to get pregnant, how do you explain someone who have no medical background nor understand the side effect of having either chlamydia or gonorrhea? How do you explain that you actually have a scar tissue caused by either gonorrhea or chlamydia?
Yeah, I would probably just explain that they had an infection, and that some of these infections, we have a model in the clinic, or I can draw them a picture, which I do a lot, and how it just sort of fills in these little fallopian tubes, and that way when the fertilized egg, one can't get fertilized, or two can't travel down where it needs to go, and so it's stuck there, and you can't get pregnant. Usually the sperm can't get through to the egg.
The other thing I wanted to ask is that you mentioned something about ectopic pregnancy with the infection, women with the infection. Is that something that is normal, that you would think every ectopic pregnancy that happens, it has to do with some sort of infection?
Well, a certain percentage, but not always. There can be other reasons for ectopic pregnancy. Once a woman has an ectopic, they're a little bit more at risk to have another. So if I have a woman who comes into me and we figure out that she's maybe somewhere between 5 and 8 weeks pregnant, and she's having a lot of pain, That's always something I want to think about, that it could be growing somewhere not in the uterus. And I would usually get an ultrasound and see.
The final question I wanted to ask, now we're in 2013, there are easier ways to get tested. Do you mind telling us what are the fastest way to test? Are there a home kit that people can test? Or talk about privacy, like our community thinks if you have STD, it's kind of taboo, you have done something that you're not supposed to do, but sometimes it happens. So talk about the easiest way to test, but also the emotional kind of effect that you see on community like us.
Okay. A couple of things with testing. For women, we used to have to do a cervical test, which was very invasive and a little uncomfortable. But now, and the same with men, it would have to be a swab into the penis. But now, thankfully, we have a urine test, so people can leave a urine specimen and then it gets sent to the lab. Unfortunately, I don't get the result back for a day or two, so that means you usually have to make a phone call, or you have to have one of the interpreters make a phone call. That's not my ideal way of communicating any sort of information to a patient. Sometimes we'll have them come back into the clinic and talk about it because they usually have questions, but that is usually it's a day or two before you get the results. The other important thing to know is that these are reportable to the state. So I have no option on that. By state law, if you get a positive chlamydia or gonorrhea in your clinic, you have to fill out the state. You have to tell if you've treated the patient, if the partners have been notified, and if you don't know if the partners have been notified, the state will try to contact you and figure out who the partners were, because it really is important that people get treated.
I'm just going to explain, because I think the right to know law about the infection is very critical. Haddii in gabadh cudurkan galmada laga helo, waxa state-ka sharci yaala waxa jira oo right to know la dhaho sharci oo ah haddii wiilka laga helo inuu cudurkii galmada ku dhacay, sharci ahaan waxa u yaala in loo sheego ama gabadha xaaska loo sheego, haddii gabadha laga helana loo sheego odageeda. That is sharci weeyaan. State-kana waa loo gudbiyaa. Dhakhtarka hadduu infection kaa baaro kaa helo, magacaaga lama diray, laakiin waxa leedahay numberkii la diray, qofkan waxa laga helay jiradii. Waa dhakhtarkana markuu xaq u leeyahay inuu inta ku yeero ku yiraahdo cudurkan xageed ka heshay. Haddaa Google dhaaftay, lacala ilaa naguma keeno, oo qof kale ka soo qaaday, ma lagu ogolay inaad ku ridid family-gaaga. Haddaadan Google odagaaga sidoo kale sameeyo cudurkii meel kale ka soo qaadayna, in waxa xaq loo leeyahay oo sharci ah oo dhakhtarku leeyahay inuu u sheego qofkii kale oo partnerkaaga ama aad isqabteen. So waxaan idin sheegaya yani waxyaabo badan oo sharciyo badan jira. Cudurkan cudur laga baqdo maaha, wuu imaadaa. Baaris sahlan la sameeyaa. So inta sarwaad idin sheeg inta kale insha Allah wala turjumaa. So I want to thank you so much, Dr. Dhalmadoonka, Rosie, Mary. This has been a wonderful, wonderful event. We so much appreciate you coming and sharing your knowledge. I hope we stay in touch and we keep in touch. Can we please give a hand? Waxaan rabaa inaan idin sheego oo aan si aad iyo aad ugu mahadcelinayo walaaltinimada aad noo soo muujiseen. Soomaali waxay ku mahmaadaa gacmo biyahaaga looga dhargaa. Haddii aan isku istaagno oon awood u yeelanay inaan wax isbarno, dadka aan expertka aan idin keeno oo wax ka barataan, the more aad og tihiin, xitaa haddayna waxa laga hadlayo dhan ayna idinka qabinin, maskaxdiina way siyaadaysaa. Qof kale oo laga yaabo ama xishoonayo ama walaac haysto ama jiradan ku dhacday ama isku dayay inuu ilmo yar haysto ama ilmo yar raadsado, waxay u noqonaysiin support. Isuran waa idin jeceshahay. La'aantiin abaar waaye. Insha Allah qofkii aan magaciisa qorinin iyo nambarkiisa meesha ha qoro. Waxaan jecelahay inaan idin soo waco oo idin dhawaa maasintiin. Halkan waxaan uga mahadcelinayaa qof walba oo volunteer noo noqday oo walaalaha soo qaaday, picture-da noo qaaday, Somali TV, everybody who is here. Thank you so much. Assalamu alaikum wa rahmatullahi wa barakatuh.
weli waxaad naga dheehanaysaan telefishinka qaranka Soomaaliyeed stuudiyihiisa ku yaala magaalada Minneapolis ee dalka Mareykanka. xaflad lagu maamuusayay sanadguuradii saddexaad ee ururka isku roon ee ururka dhalmada Soomaaliyeed ayaa iyadu aanu bartanka kaga jirnay. waxaana suurtagal telefishinka qaranka u noqotay in markaasi aanu makarafoonka la beegsano madaxa ururka isku roon Marwo Fartuun Weli. ugu horeyntiina waxa aan Fartuun ku soo dhaweeyay telefishinka qaranka Soomaaliyeed. Marwo Fartuun ku soo dhawow telefishinka qaranka Soomaaliyeed.
waa maasantahay.
Marwo Fartuun waa madaxa ururka isku roon. waxaanan ugu horeyntii weydiiyay goorma ayaa la aasaasay ururkan.
ururkan waxaa la aasasay 2010kii.
maxaa loo aasaasay?
waxaa loo aasasay markii aan aragnay dhibaatooyinka ugu waaweyn ee dadkeen haysta ee cilmi la'aanta ah. markii dadka gabadha ama wiilka ay isku dayaan inay ilmo yeeshaan ama uur yeeshaan sida dadkeena ay jaahil uga yihiin oo in waxba ka ogeyn aqoon darrada haysta. marka waxaan rabnay hadafku wuxuu ahaa in dadkeena aqoonta la baro waxyaabaha jiro oo sababa inay gabadha iyo wiilka ay uur yeelan waayaan.
Marwo Fartuun aan kula kaftamo waxaa tahay aqoon-yahanad Soomaaliyeed madaxii ururka isku roon. dhibaatooyinkan Soomaaliyana way ka jiraan. marka daryeelku ma halkan kaliya ku egyahay mise Soomaaliyana waxbaad ugu tala gashay dadka jooga rag iyo dumarba oo ayagu ay haysato dhibaatadan dhalmo la'aanta?
may dadka inta jooga kaliya maahan xaqiiqdii dadka na soo waca oo naga faa'iideysta waxay u badan yihiin dad Yurub iyo Afrika iyo Soomaaliya meel walba naga soo waca. marka hadafka isru waxaan in Soomaali meel walba ay joogtaba ay wax naga faa'iideystaan. laakiin organizationku wuu yaryahay waa 3 sano jira. ta kalena waxa weeyaan 3 sano haduu jiro organization waxay qaataan almost 5 sano 6 sano intay ay noqdaan organization weyn oo informationka meel walba gaarsiin kara. marka hadafkeena waxa weeyaan 2014 insha Allah inaan wadankii tagno oon cilmigani waxaan aan baranay aan geeyno insha Allah oo dadka saaciin. inta ka horeysana website-kii waxaas informationada gelinayna insha Allah.
waad maqlaysay oo takhaatiirta waxa ay sheegeen in dadka qaarkood cudurrada ay qabaan ay qarsadaan markaasna ay sababto in markaasi ay aakhir mustaqbalka ay dhaxlaan awlaad la'aan. marka dadkaasi maxaad kula dardaarmi lahayd adoo u marinaya telefishinka qaranka?
waxaan kula cudurradaas waxaa cudurrada galmada ka imaaday ahayn cudurradii dhakhtarada ay ka hadashay kaasoo ah in wax ay dadku qarsadaan. gabadhii ma dhihi karto in galmaan sameeyay oo cuduraan ka soo qaaday kaas darteedna way ka cabsanaysaa xitaa inay dhakhtarka u tagto ay daawo raadsato. wiilkiina sidoo kale. marka waxaan sheegaa inaad la raadsado daawada wadankii uba hadda iska xun yahay oo daawo jirinin. laakiin isbaar haddaa dareentid waxyaaba inay kaadida ku gubayso kale haddaa wiilta haddaa gabar tahay isbaar and then amrilaa kuma darinine waa ka hortegaysaan caabuqada ama scar tissue-ga ay keento cudurrada galmada keena. marka isbaara. that's all I can say.
mahadsanid. taasi waxa ay ahayd Marwo Fartuun Weli madaxa ururka isku